Great. Good morning. I'd like to thank Dr. Bueno and Dr. Matar for having me this morning speak to you. This basically summarizes our experience over a 10-year period when I assumed the directorship of the program. At that time, I just got out of training, and Dr. Murayama, who had started the program, was on his way to Philly, so we had a one-month crossover and an opportunity for me to learn everything that I needed to know about running a program. The good thing is that Dr. Bueno here is my partner, so the two of us worked diligently to try and establish a quality program with what we had, and I'd like to share that with you this morning. I have no financial or personal conflicts to disclose. So a little about the Queens Medical Center. It's the largest private hospital in the state. It was founded in 1859 by Hawaii's royal family at that time. The Hawaiian population was being decimated by a great deal of diseases that were introduced by the foreign influx. And the Queen and King went to the legislature and wanted to start a hospital to help uplift their people and improve their health. And they began fundraising by going door to door, and after a few months raised about $13,500, and true to form, the legislature contributed $6,000, and that's how the whole hospital started. It is the largest tertiary as well as quaternary referral center in the Pacific, with a level 1 trauma center as well as our bariatric center. It was in 2004 that we established the Queens CWMP, or the Comprehensive Weight Management Program, in response to the growing epidemic of obesity as well as diabetes in Hawaii. Here, you'll see this orange bar here showing a great disparity in our population, in which Native Hawaiians or Pacific Islanders suffer from obesity. Along with obesity, of course, are all the multiple comorbidities that people deal with. And unfortunately, Native Hawaiians, along with many other Pacific Island groups, have a difficult time accessing adequate health care. And so for this reason, part of the mission of the hospital and also our bariatric program is to provide accessible health care to the Native Hawaiian population. Our program was started with the philosophy of having a multidisciplinary program with multiple providers being represented, and with the surgeons being embedded into the program. And this is an interesting concept. The programs I trained in, we basically were outside of the so-called wellness center. So we didn't really see what the psychologists or the bariatricians or the other people did, and we just operated on anybody. And oftentimes we were blind to the outcomes that these patients had postoperatively months to years afterwards. Our program is a small program. We do about 125 to 150 primary bariatric operations per year. Over time, there's been an increasing number of revisions. Since 2004, we've performed over 2,000 bariatric operations, with an average length of stay of 1.2 days. Our overall morbidity is less than 2%, and overall mortality is less than 1%. Safety begins with patient selection. And in our multidisciplinary assessment model, everybody has a say, with the primary intent of optimizing the patient's physical as well as mental health. We also want to educate patients and really give them the tools to understand what life is going to be after bariatric surgery. We also want to set expectations, and I think this goes a long way to helping with early discharge. When patients hear that you're going to go home relatively pain-free, you're not going to take a lot of narcotics, from the very beginning, upon entry into the program, that's what they expect afterwards. They're not going to expect a ton of narcotics to go home with. And so everybody in the program toes that same line. And oftentimes, patients, as they go through the program, will speak to other patients. And the other patients will tell them, yeah, I had no pain. I got sent home with a prescription, I didn't fill it. And so somehow, with that peer pressure type phenomenon, patients have this expectation that they're going to go home relatively pain-free. Another philosophy of our program is that all members, psychologists, bariatrician, and even our nurses and everybody else has an equal veto of a patient during our patient selection committee. And patients, I think, get better care that way, where the surgeons just don't bull rush a patient through, but everybody has a particular say in the patient's well-being afterwards, because they're going to be responsible for that patient. So it creates a sense of ownership over the patients in the program. So like most of you, the multidisciplinary model works by having input from everybody, including the surgeons, and then we come to what's called the patient selection committee. And at that point, the patient's candidacy is discussed, and if the patient is deemed a good candidate, they get through to surgery. They meet one of the surgeons in the program, and what operation they get is discussed. If at that point they're not ready, they get back into the cycle and they go through a longer period of evaluation. Typical average patient takes about 3 months in our program to get to surgery. Our patients also then get evaluated by an anesthesia preoperative evaluation center. We call it APEC. And this provides us the opportunity to have our anesthesia team, which is basically one group, evaluate the patient and assess for anesthetic risk. Here, expectations are also upheld, and patients are further educated. Another tenet of our program is that we have a team. Part of reducing costs is making sure that everybody has ownership and everybody's invested in the program, and having a team allows us to do that. So we use the same anesthesia group. They understand our protocols, they understand how our patients can be best treated using best practices. We try to use the same OR crew. There are several models out there that will show that if you just have one change in your OR team, disaster can happen, meaning long turnover times. And so we try to keep the same team over and over to help facilitate turnover. That's not always the case, but that's certainly our goal. And we also have the same post-operative nurses in the recovery room, as well as a designated floor that all patients recover on. I worked with a vascular surgeon as a resident who taught me that boring is good. A boring day in the OR is a good day, and so we want to keep it boring. We want to standardize the operation. Myself and Dr. Bueno are always joking that we're the same person, because when there's a decision made, it's across the board. We follow the same protocols, same procedures, and keep things very routine so that the OR staff is not, thrown off by something different. And in the post-operative period, the patient had the same operation, whether it was myself or Dr. Bueno. And we will operate with 2 surgeons to keep times down in the OR until our residents are proficient. And we won't delay an operation to get the resident the experience. We'll have our expectations of our residents heightened so that they can match the times that we want them to. A typical operation ranges from an hour to about an hour and a half. Standard postoperative pathways, again, are designed by the team and, again, reinforced on the floor. Our standard post-op, Hawaii, series of islands, we have a captive audience, and so we follow up patients very closely at 1 week, 1, 2, 3, and 6 months, and every 6 months thereafter if patients will come back. And again, being on an island, you can't go far, and we will find you. Again, and a routine follow-up is with all providers, the surgeon, the dietitian, the bariatrician, and close communication is maintained with the primary care providers. Safety is also embedded into the program. We have an amazing data analyst named Courtney, and Courtney basically took it upon herself to start mining the MBS QIP data, as well as start receiving flags from various areas. For example, if she starts noticing a lot of no-shows because she's not able to fill in the data, she starts digging deeper and looks into the patient's EMR and looks for any type of unnoticed ER visits. Or there are flags from what's called HHIC, which is the Hawaii Health Information Corporation. And this particular corporation will amass data from various other hospitals in the state. And if a patient of yours is tagged, it'll send you a flag saying this patient went to the ER in an outlying hospital. Now, there's no one nurse, no one person in the system that's responsible for these flags. It's an option that we can opt in or opt out of. But again, Courtney took it upon herself to take these flags and start again, if a patient is pinged, to start digging deeper and finding out what happened to this patient in the ER. And if it's seemingly related to anything bariatric, she'll make contact and have the patient follow up with us. Or if for some reason there's been a series of no-shows and the patient for some reason is having a breakdown psychologically and has been a shut-in, she'll encourage them to come and get the care they need. So The data analyst oftentimes is someone who looks at things retrospectively, but because of her unique position in our program, she's able to get care in real time and prevent some major disasters from happening. So the take home from this is that we all have a role in patient safety, regardless if you are the frontline nurse or physician. Even the data analyst in their position can find ways to improve patient safety. And because of that, she was recognized as Employee of the Year by the hospital system. So leading into the quality, the MBS QUIP data analyst, again, has an important role. Through her retrospective chart reviews, she's able to benchmark our outcomes with national data and let us know if we're outliers in any one particular area. She holds monthly QI meetings along with our patient selection committee meetings, and then gives us an idea of where we're missing the mark on. She leads quality improvement projects. One, for example, is reduction of SSIs, or surgical site infections. She noticed that patients coming from the Big Island of Hawaii, where there's a lot of catchment water as their primary source of drinking, cooking, and bathing, had a slightly higher rate of SSIs. And so this is something that we're keeping an eye on and potentially may help the patients coming from that particular island. We also teach residents, and as a result participate with monthly M&Ms, where it's ABC, accuse, blame, and criticize, but it's a good way for you to have your data reflected upon and learn from. So cost efficiency is something that we wanted to really focus on, and a couple of the tenets of maintaining a cost-effective program is knowing how much you get paid personally, how much the facility gets paid, the cost of your operation, which includes your OR time, the cost of your personnel in the OR, and the amount of junk you open in any given case. Also important is knowing what phases of care cost you. Oftentimes we'll take someone with OSA, or at least in the early beginning of our program, put them into extended recovery, or in some programs in the ICU. And this costs a lot over the standard wards. And again, know your length of stay. So the idea is that a surgeon in the know is dangerous, and you have to know how much you get paid and how much you make in order to be able to be a decision maker and come to the table with the administrators in your hospital. So by knowing how much you get paid and how you get paid, you are able to negotiate not only with the hospital, but with the insurance programs that pay you, and develop contracts that pay you more and pay the hospital more. You're also able to eliminate certain insurance plans which may not pay the cost of your operation, so you're not doing free care. I had to understand that we get paid by a DRG, designated related groups, and that in concept, this is basically a bucket of cash that you get for each and every patient you operate on. And so this insurance company will give you whatever your contracted rates are and say, here's the money. The more money you can keep by reducing the expenses, the better for you. And so your job is to mitigate the amount of money you're throwing out. So that means reducing inefficiencies, poor turnovers, again, getting the same team, showing them appreciation and educating them, gets them, again, involved and invested. Equipment and supply waste, select lower cost alternatives. One clip applier is about $250 versus another brand, which is about 3 times that. So find an alternative that works for you but is cheaper. Standardize. If you standardize your caskets or the packs and the sterilized equipment, it allows the team to turn over things faster, so standardize everything. Seldom used supplies should be put in a bin or in a bag that says, do not open until I say so that the OR team is not throwing away devices that aren't used. Be frugal. We used to use sutures and cut them to 6 inches, use them one time, and then replace with another cartridge, which is about $50 pop. So take the whole length of the suture and use it. So practice in the skills lab and get your suturing down. Does this really help? And it goes to Dr. Lim's points. Use evidence-based medicine to drive your protocols. Ask your colleagues, does this work? And review your data. So when we first started, when you guys were growing up, right, like me, I wanted the 64 box of crayons. I wanted everything. But did you really need the 64 box of crayons? Probably not. Who would use some off blue? Not many people. But your mom wanted you to get the 8-pack because that's all you really needed. When we first started, there was a great honeymoon phase. They opened 2 and 3 of everything for me, gave me whatever I wanted. But then in 2010, we had a huge financial crisis in the hospital. And like many other people, cash was something that everyone was trying to save. And we were told that you had to save money. And we realized that before they tell us what staples we can use or how we, what equipment we can use to operate, we needed to take control. And understanding that gave us the ability to take control of our operations. So again, the same things, only opening the necessary equipment, trying to reduce staple loads, suturing rather than stapling. We used to staple the entire JJ. Now we suture a good portion of it to reduce costs. We eliminated staple line enforcement, hemostatic agents, drains. CMS came out with the NEVER events in about 2008. And so one of the major NEVER events was a UTI, a CAUTI. And so we said, okay, let's not put catheters in, so no more CAUTIs. And so that was another way of reducing how much you were throwing out from your money, your cash bucket. We even went as far as saying no more Band-Aids. I mean, we kind of went a little too far. So no more Band-Aids, just steri strips. But you know what? The patients don't need Band-Aids. So that small savings over time equates to something big in over 10 years. So in a nutshell, I don't know where Rob got the $11,000 per day. That's the military for you. But in the private sector, we spend about, we say that an average hospital stay is about $1,500. And so we're able to save that by actually reducing length of stay. And so that's more money that remains in your cash bucket. Avoid unnecessary higher levels of care in an extended recovery setting because a patient had OSA. A 15-hour extended recovery period would cost about $6,000. That's more money taken out of your bucket. We did studies to show that OSA patients don't necessarily need that, and they can go up to the regular floor, and as a result, $6,000 is kept with you. So cost efficiency, eliminate routine imaging. We had to do that. Again, going back to what Rob had mentioned, we eliminated routine labs postoperatively. Except for an H&H because our patients remain on heparin. We start them on 5,000 sub-Q heparin in the morning prior to the OR time and go Q8 after that. We don't send them home on any DVT prophylaxis. Again, eliminate the routine use of higher levels of care and use similarly several of the ERAS protocols that Dr. Lim had mentioned and follow-up calls. I'm being told to hurry up, and so in all, you know, again, with these measures, you save a lot of money. So a quick summary there. Thank you very much.